Okay, everyone, why don't we get started? I'm going to do introductions today. We are happy to have the glamorous headache docs here today. Both residents in our program. Natalia Murinova was trained by Sylvia Lucas and is in the headache clinic, and Jenna Kanter, trained by Natalia pretty much, and now in the headache clinic. And they've been a wonderful addition to the neurology program. Lots of good advice for headache patients, and they have 5 new things in headache today. Thanks.
So welcome, everybody.
Welcome. Thank you, Holly.
Okay, so we're going to be kind of flipping between me and Jenna, but I'll start the first part, then Jenna will do the other part, and we'll try to answer your questions. So we actually called it new thing in headaches, so we're not going to be accused if we're not counting correctly exactly 5, so change the title. So we have no financial disclosures, and today's talk is about new developments in headaches, so that's why we're here today. So why headache, diagnostic criteria update, CGRP, neuromodulation, the glymphatic system, and cortical spreading depression. So why are we talking about headaches? So as you all guys know, headache is one of the most common reasons that leads patients to consult a doctor in clinical neurology settings. So all of you guys who are not going into headache, you are going to see patients with headache. I can guarantee it, right? You guys who have been doing other specialties can confirm it. Among primary headache disorders, migraine is the most common. It's currently called neurovascular because we're going away from the vascular more to the neural brain dysfunction, and recurrent unilateral headache lasting 4 to 72 hours. And I'm going to go into the criteria in a little bit. So headaches, as you know, are extremely common. More than 90% of people do have headaches. And migraines are especially the most common type of headache we see. We actually see mostly chronic migraine in our population. From American Migraine Prevalence and Prevention Study, it shows you the first number is 56% of patients suffering with migraine received a migraine diagnosis. So less than half of the patients who have migraines are actually diagnosed. And 39% of patients, migraine patients who are eligible for preventive treatments, 39% are eligible, but less than half actually receive preventive treatment. So migraine does remain one of the most underdiagnosed and undertreated neurological conditions, and it has large and substantial socioeconomic effect in developed countries. So the first step is accurate data. So that's what we tell our patients. We're like accountants, right? If you come to us and you say, am I making $1,000 or $30,000? It makes a big difference. So it makes big difference to us. Do you have 1 headache day per month or 30, right? And most people say, well, I don't know. Let me think about it. So you might want to tell them, you know what, guys, you need to do some kind of headache diary. We recommend electronic headache diary, such as iHeadache or Migraine Buddy, because this one you can actually import into the directly electronic system. So they can email you the data and you can just put it in and it's part of your note, and it puts in exactly how many headache days, what did they use, what caused it. So it tracks headache days, medication use, and advanced reporting. It's very sophisticated. It will tell you the diagnosis for you. So it actually uses IHS criteria. It's 5-star reviews and it's free. So now currently we use International Headache Society criteria, and we have in our audience Melissa and Mui, who are our nurse practitioners, and Melissa did a study looking at how many primary care providers actually within the U system use IHS criteria. It turned out less than 16% of physicians are familiar with International Headache Society criteria. So this is where you start your diagnosis. If you don't know this, then you don't know the diagnosis. And so that's the key that I'm going to tell you is start with the correct diagnosis. And if you say, how do I start? Again, telling your patients about the headache diary, and then it will actually come up with the diagnosis. But in order to diagnose someone with migraine, you have to have at least 5 headaches in lifetime. Why am I saying that? If someone comes to you with first ever headache, you can't diagnose them with a migraine. It could be probable migraine. Watch out, it could be something secondary. The patient has to have at least 2 either unilateral headache, pulsating, moderate, severe, aggravated by routine activity. If you had one question, and Dr. Spain taught me that when I was in residency, if you had one question to ask a person with headache, it would be, what do you prefer to do? Not what do you do during your headache, what do you prefer to do? And if you prefer to lay down in a dark, quiet space, by definition, that's a migraine. If you say, no, I'm restless during a headache, in general, we'll talk about it, that's a cluster, that's not a migraine. If you get into chronic, sometimes those criteria are really, really difficult. So we currently lump headaches, and so instead of splitting, so many migraineurs will have combination of tension-type headaches and other types of headaches. So you want to put it all together, and you want to say, how many total headache days do you have per month? You don't want to tell them, okay, what is the different types? That's not really helpful to you. And if they have more than 15 headaches of any types of headaches, and half of them meet the migraine criteria, and it's defined as patient knowing that it's migraine or using a triptan and or having migraine features, that's a migraine. So this is, we're currently doing a study, the majority, battery ran out. So can you guys hear me here? So a majority of the patients that we're seeing actually have new diagnoses of chronic migraine and medication overuse. That's something that physicians miss. So it's really interesting to us. So this is a slide from Steven Stahl. The book is called Chronic Pain and Fibromyalgia. And from this, I can explain to you majority of the treatments that we currently use for migraine. So his main emphasis is that at the end, you have activation of the pro-pain system. There's a lot of concentration in current migraine research on CGRP. How many of you have heard of CGRP? Hopefully all the residents, yeah? Okay, awesome. And so, and basically that's the pro-pain system activation. That's currently the research has the biggest emphasis on anti-CGRP antibodies. So if you Google migraine 2017, that's what you're going to read about. But what is underemphasized is that if we have an anti-pain system and kind of simplistically put together that's serotonin, endorphins, norepinephrine, and so it turns out that a majority of the treatments, such as triptan, most of you guys know the triptans is acute treatment, right, for migraine? So like Imitrex, if you say, how does it work, Natalia? It works through serotonin receptors, decreasing CGRP. If you say, how does Botox work? Decreasing propane activation, CGRP, substance P, and all of the propane chemicals. So all of the medications that we're currently using, I could explain on this model that we're doing.
What does CGRP stand for?
Calcitonin Gene-Related Peptide, but it has absolutely nothing to do with calcitonin physiologically.
So currently, these are the potential migraine treatments. So again, on the previous slide, you had the propane activation, not only CGRP, but also substance P, stands for substance pain, bradykinin, vasoactive peptide. So it's more complicated. It's not CGRP only. But those are all the targets that we're looking for. And currently, the basic understanding is that in the brain, it's the thalamus, hypothalamus that decides, so to speak, to activate the alarm of headache, and then activates the trigeminal nerves that then release the billions of neurotransmitters that we currently associate with pain. Again, very complex. So CGRP, again, the current concept is that if you have normal levels of CGRP and you're exposed to light, sound, smell, or pain, you're going to be fine. If you have increased levels of CGRP, then you're going to be exposed to light, you're going to get light sensitive, sound sensitive. Pain is going to be allodynia, increased pain perception, and you can get nauseated. It's all attributed right now to this. So this is the model that currently headache operates on. So again, calcitonin gene-related peptide and migraine. So from the early hypotheses that were formulated in 1985, pieces of evidence have reinforced the idea that calcitonin gene-related peptide is a key neuropeptide in migraine pathophysiology, up to the recent evidence of anti-migraine effect shown by the CGRP receptor blockade. Again, stimulation of the trigeminal nerves causes release of CGRP. The emphasis that I'm going to have, this is not just migraine, any headache. So sinus headache will release CGRP, cluster, CGRP, any tension type headache. So it's not specific for migraine diagnosis. Perivascular CGRP causes neurogenic inflammation. Blood CGRP levels increase during migraine attack, and if you give exogenous CGRP, you can provoke a migraine attack in a migraineur. Initially, we were going to CGRP receptor antagonists. The issue there was with the oral medications that they had a lot of liver toxicity, and because of that, the move was to develop monoclonal antibodies. And so the recent attention has been focused on 4 monoclonal antibodies targeting the CGRP pathways, all of which are currently in phase 3 clinical development. Again, triptans normalize CGRP as they alleviate migraines. So triptans are serotonin 1B and 1D. For boards, how you remember it is one bad headache, so B and D agonists, they're considered gold standard for episodic treatment. They block the release of CGRP and return CGRP levels to baseline values as they alleviate headaches. Currently, it's both for prevention and acute treatment. I'm just going to go through this. All of them look very, very similar, but what do you see? So the red is placebo. The blue here is, and all of them are Zumab. So there's galcanezumab, and this is from Dr. Dave Dodek's published trial from Lancet. And what you can see is you look at 1 month, 2nd month, 3rd month, and you look at currently the standard is headache days. That's what is used, to try to put it together. And you can see already within the 1st month, you see separation from placebo that is sustained in 3 months, and they're looking now on more longer-term data, like 6 months, a year, and all of them look very, very similar, where there's dramatic dissociation, from placebo. Again, you might say, well, is it really significant or not, in patients' lives? And they might argue that yes. So eptinezumab, again, very similar data. I'm just going to kind of go through this. And again, studied in chronic migraine, and again, you can see reduction in migraine days per month, and comparison compared to placebo. And placebo is incredibly efficient in decreasing migraines as well. So that's a problem for all the migraine trials. And what they have finally figured out, that placebo actually decreases over 3 months. So a lot of times the current neuro trials are done where you wait up to 3 months before you start giving the active medication versus placebo, because placebo is not sustained past 3 months in most of the trials, interestingly enough. So again, you can see very similar results with fremanezumab in episodic and chronic migraines, and this is chronic migraine data. So again, you can see within the 1st month, right, very significant separation from placebo within already 1 week of therapy initiation. All of these drugs are given either intramuscularly or IV, and again, it's very, very similar data. So kind of to sum it up, so most of them are given, so eptinezumab is given IV, the rest of them are given sub-Q, most of them are given in different intervals from anywhere from a month to 3 months. And what is very interesting is that suppression of the CGRP can stay for months later. The main kind of currently contraindications for the studies was pregnancy, because they didn't want to study this. And what we're finding, because we've had already patients in the previous trials, was very, very effective, but the minute they stopped getting these, they went back to their baseline. And so that's something to think about. So, but this is where migraine treatment is going, very similar to MS treatment and to these infusion therapies. So what are the potential issues against CGRP? And so some study subjects develop anti-drug antibodies. Now, CGRP is a potent vasodilator in myocardium, and we don't know whether decreasing the levels increases risk of heart attack or stroke. Also, we don't really know because it's present everywhere. It's in the kidneys, bones, GI. We don't really understand why the CGRP exists, and is it really smart or not to decrease the levels. In healthy subjects, probably okay. There's some controversy with people who have hypertension. They think it might be protective. So to favorite topic of Dr. Ransom's, right, was here, glymphatic system. And so who has heard of glymphatic system here? So everybody raised their hands. So it turns out, you can look up the YouTube video. I'm not going to go into extreme detail, but to tell you what the glymphatic system does is cleansing your brain from amyloid and other neurotoxins. So what was new is Rami Bernstein decided, why don't I look at this in a model of migraine? And so he published in April of this year, Cortical Spreading Depression closes the perivascular space and impairs glymphatic flow, implication for migraine headache. So we know, or currently the model of migraine is that it starts with cortical spreading depression. So cortical spreading depression is a short wave of initially propagating wave of altered neuronal activity. There's brief excitation followed by prolonged inhibition, and we definitely attribute aura to this because it starts in the occipital lobe and then continues spreading. This has been known since 1944 and first introduced by Lau in 1944. And so patients with migraines at baseline exhibit high cortical excitability. And so we know, I'm jumping a slide, that there are this is work from Dr. Marcel Begal and Lipton, who are epidemiologists who looked at modifiable factors for migraine progression. They found that it was frequency of migraine, obesity, medication overuse, caffeine overuse, but interestingly enough, sleep disorders and traumatic brain injury also there. And we now looked at our subset of over 2,000 patients. We're actually putting it into poster. And more than 70% of our patients report sleep disturbance and sleep difficulty, 70% of migraineurs. So again, this was the preliminary data, 6 months ago. Now we're to 2,000 patients. And the data are staying about the same. Now it's about 69% that are showing indoor sleep problems. So what they did, what Rami Bernstein did, he had a novel in vivo method. He was using 2-photon microscopy to visualize the perivascular space. The mice underwent surgery to have imaging window in the skull. And then what they did is they were inducing cortical spreading depression, either using pinprick or potassium chloride. And then they were imaging, and the cortical spreading depression was confirmed using potential recording. And what it shows you is they were using actually the mice that were developed here at the University of Washington, the fluorescent mice, the green mice. And the negative space is the empty space. That's the perivascular space. So on the first, A slide, you see it artery, and then around it PVS. That's what stands for perivascular space. And you can see that cortical spreading depression causes closure of arterial and venous perivascular space. This is in vivo. So you can see on the D, so this is progression, temporal and in time. You can see it's completely closed off. And what he basically concluded, and this is now being studied, he's moving now into human subjects. So this was all kind of the mice studies that they initially did. So this is, if you say, what is the summary of this slide, and to show you, so currently what we understand, the glymphatic system might be close by migraine attack. What is the implication? Well, the implication is that a lot of our patients are actually complaining of cognitive and other disabilities, and we don't know if it's the accumulation of amyloid, but the glymphatic system definitely is impaired if you're not sleeping, and is impaired if you have traumatic brain injury. So we have actually now developed a sleep shared visit in our headache clinic to try to address the sleep problems, and we just led the first visit that was very successful, right? So moving to you, Jenna.
Is my mic working? Can you guys hear me?
Yeah.
Okay, great. I have the clip on, so I could do this TED Talk style if I had a little clicker. Okay. Do you want to advance slides? No,
okay. I can address that.
That's okay. No, so I guess our last new headache topic for today is neuromodulation and headache. And by way of sort of segueing into that, I'm going to talk a little bit about why we care about neuromodulation and headache. So one of the big reasons is because of medication overuse. So having new tools to deal with that is very exciting and attractive. And just as a quick recap for the residents who slept through your entire headache rotation and all of the talks that Natalia and I have given before, medication overuse is a huge problem. We see it with all of the acute medications that are used for headache, and all the way down to simple analgesics like Tylenol. I put the little asterisk here because the sort of usual definition of use of an acute medication more than 10 days a month is probably a little generous. And certainly some patients have genetic predisposition to medication overuse or rebound, and we see them developing that at much lower frequencies of use. And that's particularly true with opioids, And even more true with the butalbital compounds like fioricet and fiorinol. So this is just my public service announcement, which we repeat over and over again to all of you, which is never, ever, ever start patients on these medications. They might tell you, oh, I used to take that years ago, back in the 50s, and it was great. You have better tools now. And we learned actually at a recent Headache Society conference from a European presenter that these compounds are actually banned and unavailable in multiple European countries because they're not thought to have medical benefit outweighing their risks. So moving on. So medication overuse, we have a lot of tools involved to treat that, and this is not a talk specifically about that, so I'm not going to go into it, but there are a lot of limitations to the tools that we currently have available, particularly medications and medication side effect issues. So we're always looking for new ways to address that, and the neuromodulation may be helpful there. And the other is just that our acute migraine treatments have limitations themselves. So you've all seen patients who don't respond well to triptans or other acute medications. They don't work well, they cause side effects, the headaches come back, lots of issues there. And that's certainly true of our preventive treatments as well. So what else is out there? Well, there's Botox, and everyone knows about that already. So there's patients who have tried that and it didn't work for them, or it's just not acceptable to them for a variety of reasons. So neuromodulation is kind of the new kid on the block for both preventative and acute treatment of headache, and we're very excited about this field. So that's what we're going to talk about for the next few minutes. We have currently 3 devices that are FDA approved for treatment of different kinds of headache disorders, and I'm going to go through each of them one at a time. And we actually have sample devices available to show you what they all look like. And some of you were here a little early and got to come up and kind of play with them at the beginning, but if anyone wants to play with them, either now Natalia can hand it out to you, or you can come up afterwards and pick them up, look at them. The TMS device in particular is pretty easy to try for yourself if you want. If anyone's having a migraine today, you can treat it. So first one I'm going to talk about, Natalia's like my Vanna White.
I think Wonder Woman.
Yeah. It's the migraine tiara or the Wonder Woman or the Star Trek device is what our patients kind of know this as on the internet. So this is the Cephaly device. Bruce can pass it around. We have one so you can see how little it actually is, but that's a picture of what it looks like on the patient. So it has a little sticky reusable electrode, kind of like an EKG electrode that makes contact with the skin, and then the device clips onto that. It's battery operated and rechargeable. And this device was FDA approved in 2014. I think most of the residents who have worked with us have heard us talk about this with patients. And it is FDA approved specifically for preventative treatment in episodic migraine. And I'll talk a little bit about why that is and other ways that it might be used. I have a sort of excerpt here from one of the papers that was instrumental in getting this device approved by the FDA. And this is rich with interesting information and thought-provoking information about Cephaly, so I'm actually going to spend a fair bit of time on this slide. A couple of things that I really like about it. One is this graph up here is a lovely illustration of what Natalia was just saying about how the placebo effect has a certain half-life and tends to decrease over time. So you're seeing on the y-axis, that's decrease in number of migraine days, which is kind of our standard, usually the primary endpoint for most of these studies. And the active device is shown with the red squares, and a sham is shown with the black triangles. And what they did to come up with an effective placebo was they have a device that it does turn on and it creates kind of a tingly sensation, but it's not the full stimulation level of the active device. So the patients had no way of knowing whether they were getting the full stimulation or not. And you can see that there was essentially no difference between them. At the first month, both showed a modest decrease in headache days. And then after that, you start to see this nice separation between the active device and the sham device starts trending back towards baseline by about month 3, which is a great illustration of how placebos tend to work. So, and it's also an illustration of what you just saw on the last slide, which is that this device really does need to be used for a good 2 to 3 months on a regular basis to see the benefit of it. So that's something we really emphasize with patients, and that's something that's quite typical of preventative treatments in migraine. Most of the preventative medications require a similar time frame. And one of the interesting things about the CGRP inhibitors is that they are not showing that delay. So the patients on the CGRP medications seem to show a pretty brisk response to those medications, which is an interesting commentary about how they might work.
How
yeah.
often do you have this thing?
Yeah, so it's used in the preventative protocol. It's used for a 20-minute session once a day. And the patient they can be, they don't need to be lying down. They can be walking around their house or watching TV, or we encourage them to use it as relaxation meditation time. And people often say it makes them feel sleepy, so they tend to do it at bedtime. And it's, if anyone actually wants to try it, we have an electrode here if anyone wants to see what it feels like. So the other thing I'm going to point out is some of the information down here. So primary endpoint of the study was decrease in migraine days, and you can see the split there between the active device and the sham device. And you can see the percentage decrease, about 25%. And it's not an amazing number. That's pretty comparable to the outcomes that we get on average with preventative medications. And I think that as with most treatments in migraine, if you really look into this data, you see there's kind of responders and non-responders. So the patients who respond to Cephally, we often see them getting a much better response than 25%. And migraine attacks, more or less the same thing. Interesting thing here, and this is not a primary endpoint, was that there was a significant increase in total headache days. So what does that mean as opposed to migraine? Well, as Natalia said, we're lumpers. A lot of patients have both migraine and tension type headache. I would venture to say the majority of our patients do. And so this is sort of a signal that the Cephally device probably works on tension type headache and might work on other types of headache as well. It's not FDA approved for that indication. Not a huge impact on severity, and this is one of the exciting things that ties back into the medication overuse. So we saw a significant decrease in acute drug intake in those patients that were using the active device, and that's what we're really excited about. So any questions about that before I move on? So there's some questions that are still kind of dangling out there for Cephally, which is there was a signal in the data, which I didn't show here, that shows this device actually might be more effective in people with higher frequency episodic migraine, which is more in like the 8 to 14 days a month range, than the low frequency. So why is that? Is it effective in chronic migraine? It wasn't studied that way. We believe it is, and we frequently use it in chronic migraine. And might it be helpful for other headache disorders, tension type headache, post-concussive headaches that don't really meet criteria for migraine? Again, our experience as a center has been that it probably is useful for a variety of migraine disorders. And now that it's on the market, we can prescribe it off-label for whatever we like. And then I also put down the bullet point that this device may well be useful for acute treatment of migraine as well. It's actually indicated for that in Europe and in Canada. The FDA didn't feel that the level of evidence sort of rose to their threshold to approve it for that purpose, but there is some data in smaller kind of open label trials that patients can use this in addition to their daily preventative session. They can actually put it on and do a session with it when they're feeling a migraine coming on. And we have many patients who do use it that way and find it effective. And there's some interesting kind of studies going on looking into the mechanism of how it works, and the mechanism of action in acute treatment versus preventative is probably different, but we don't know a whole lot about that yet. Just some logistics on this device. Cost is pretty reasonable compared to the other devices, as you'll see coming up. So it's $350 out-of-pocket cost, plus a modest ongoing cost for the electrodes that have to be replaced about every 3 months. Patient orders it online. They do need a prescription from the physician to order it. We have not found that insurers are covering the device at this point, although the VA does, and we'll order it from prosthetics for patients if one of you recommends it. And patients who have HSA or FSAs can use those funds to purchase this device tax-free. So any other questions on Cephally? Okay. All right, next device I'm going to talk about is the single pulse transcranial magnetic stimulator. It's called Spring TMS, is the brand name. We have a slightly older model of it available here. The newer model looks somewhat similar but is a little bit lighter. And this is what it looks like when it's being used.
We can go back to this.
What?
We can go back to this.
Oh, yeah. So the patient holds it up. This is just for a very brief pulse. They're not sitting there holding it for a long period of time. This is some data about that. So this is sort of, in some ways, the opposite of the Cephally story. It was initially approved only for acute treatment of migraine, and actually specifically for migraine with aura. So it was thought that this device would be most effective in people who have significant cortical spreading depression emanating from the occipital cortex, which the aura is kind of a marker for that. And this is the very late breaking news that we just got into the slides before we came in to give this talk, which is that within the last month, the FDA actually updated their indication. So this now can be prescribed officially for both preventative and acute treatment and for migraine with and without aura, because new data came along demonstrating that it was effective for those. So this is a graph just looking at, again, they used a sham stimulation. So this device doesn't really feel like much when you use it, but it does make a noise when it activates. So they had a sham device that made the same noise but didn't actually deliver a magnetic pulse. And they did see a significant difference in, this is looking at the percentage of patients who are pain-free at different time points after using the device to abort an attack. And again, I will point out that it's not a great response, right? 40% of patients pain-free, but that's really very comparable to the average response rates to triptans. And this is going to be a little hard to read. The type is really small. I couldn't find a better figure to talk about how this works as a preventative. This comes out of a poster that was presented at one of the headache conferences. For some reason, it doesn't look like they ever really properly published this. So take this particular study with a grain of salt, but it sort of shows why we're transitioning to thinking about using this device more as a preventative. This was a group of patients, I think about 60 people who were not only people with chronic migraine, but actually people who were defined as being in medication overuse, so our most refractory population. And the green bars are people with migraine without aura. The blue bars are people with migraine with aura. They had pretty half and half. And it's sort of odd the way it's shown, but they're showing a number of migraine days. So a bigger bar is better because it's moving down the scale. So they were starting out at 25 migraine days and ending up at 16 with the green bars there. And this was not a study that was powered to get statistically significant results, but you can see there was a really nice trend towards improvement in both of these groups. This was open label, but they went out to about 12 weeks, and we're still seeing a pretty sustained and, in fact, improving response ongoing. And that also, again, gets to that point that these neuromodulation devices seem to work progressively better with prolonged use. So you saw that Cephaly continued to decrease migraine days out to 3 months, and there's been some later data that shows up at our conferences that even going out to 6 months of use, people will continue to see further drop-off in their migraine days, and that may well be true for the Spring TMS as well. So this is logistics and pricing on it. So this device is very expensive. It cannot be purchased. It has to be rented from the company, and this is the price structure on that. Generally speaking, as far as we're aware, there are no insurers that are paying for this device directly, and the company will help patients to work with their pharmacy benefit coordinators to try to get reimbursed for a portion of it, and I have heard that some patients are successful in doing that. We don't have a lot of experience using it yet to tell you how often that's successful. I would be fairly certain that public insurance like Medicare and Medicaid is not participating in this. So there's some limitations there because of cost. And they do give a discount for the first 3-month period. It still costs, I think, a few hundred, but it's maybe more like $300-400. So a patient can try it out with a little bit less financial commitment. Any other questions about TMS?
So I have a question about the patients that respond. It's always a fraction of your total patient population. And I'm just curious if there's anything distinctive about those patients. If those patients that respond to this might respond to the other, might respond to triptans or not.
Right.
Or if you're a strong placebo responder, is that a separate category of migraine?
Go ahead.
So what we're looking at right now, and we have actually done a poster, is patient preferences. And so what we're seeing mostly in headache clinic, majority of our patient population here in Seattle is very young and very educated. And majority of the young and educated population does not want drug medication solely. They want non-medication approaches as first approaches. So you could argue that people who preferentially prefer to go into these studies, is their inherent, belief that that's better, for me, right? I mean, the self-selection that we all see. And that's very, very significant. We're seeing that there is a very small percentage of population who wants only non-medication treatments solely, but very significant proportion of population when they come to us, they say we don't want drugs, we want non-medication approaches.
But still,
Right.
only a third of those
Right.
people are headache-free.
Right.
Why is that third headache-free? Is there
And-
something special about that group?
And so what they saw actually, and what is really even interesting, going back even to the anti-CGRP antibody, they have 20% of population who just after one shot are completely headache-free. And so what all the companies are starting to do, they're starting to have genetic data, and kind of long-term data, but it's, as you know, genetics is extremely complicated because of the epigenetics, mitochondria, and, layers and layers, and they're trying to figure out, to answer your question, no one has figured out what is different currently about certain population of patients, why there are super responders, but we think that it has to do probably both the genetics and environment and the priming, of the brain. Some people are very, very susceptible to responding to things, and some people don't respond to it.
But no one's
No.
uncovered
No.
any particular
No.
feature of
No.
the
They
headache
would love
that
to.
would tip
No.
you off.
No. Yeah, that's a very good question, though. So the question, again, if I didn't repeat the question, is how can you decide what is different about a population of a patient percentage who will respond to a certain treatment and or not, specifically TMS or cephaly? And we actually have our data where we're going to try to do, we have about 400 patients have tried cephaly, and we have a very small amount of patients who returned it, so we want to try to figure out what do they think, from our own data here. At TMS, we have only a few patients. It's like literally a handful because it's a newer treatment and much more pricey. So I don't know if that answers your question.
It's a very thought-provoking question
Yeah.
that we don't have good answers to.
Yeah.
So our practice is to try and see who responds.
Just a curiosity, did you come across anything with the Spring TMS device in terms of issues with it reprogramming shunts or causing other local negative effects?
Yeah, I think it would be contraindicated in a patient who had a shunt or any kind of intracranial implant. I didn't actually include any of that information. That was probably an oversight on my part. So contraindications for these devices, it's a little different from one to the next, but there's very few of them, as you would expect, because they're not a medication, so you can use them in people with heart disease and who are on all kinds of other meds, but we don't, they're generally considered contraindicated in patients with any kind of metallic implant in the head, stents and things like that. And I probably wouldn't try to use the TMS in somebody with a shunt. I don't think I'd dare that. Okay. Amy?
Explain a little bit about how it works and how it's helping.
Yeah, it's a good question. So I can give you what's been speculated upon, but we don't really know. I mean, originally the sort of development of this device was targeting cortical spreading depression, which typically starts in the occipital cortex, even in patients who don't get aura, but that's why auras tend to be visual, or we believe that's the case. And they sort of created it to inhibit cortical spreading depression. So that's why it was made this way. That's why you put it on the back of the head. That's why they originally looked at it migraine with aura. There's probably far more than that going on, because we know that cortical spreading depression is not the only thing happening in migraine. It's probably not even the cause. It's more of an epiphenomenon of migraine, and there's much more going on than that. So people are looking, they're now starting to do more like PET studies, thinking about, does it somehow modulate kind of functioning of the limbic system, but that's really early stages. I don't know if you have any other comments on that.
Yeah, I mean, this always comes up at all the headache meetings. The excellent question was, how do these work, these devices? And, if you ask, let's say, Dr. Silverstein, he will say exactly what Jenna said. Neuromodulation is the word that is being used. What is neuromodulation? If you try to push him, what does it really mean, right? And so then they're going to start talking about autonomic nervous system and increasing vagal nervous system. It's like people use these phrases, but, we don't have enough data to really, we have only theories at this point, but it's a great question.
Any other questions about the TMS?
I think the enthusiasm of the therapist plays a role.
Absolutely.
As it does with everything, right? I mean,
Absolutely.
50% of our benefit to our patients as clinicians is placebo effect. I think that's just as true for devices as it does for drugs and everything else. So I would say that, Natalia and I and our nurse practitioners probably all do that. The Cephaly is the device we recommend most often because of its affordability, and we talk it up, right? We tell patients, we've had great success. We've had 400 patients try this, and the majority of them have benefited. That's sort of part of how you sell it. But that's not good enough. That's why we showed you that the placebo effect kind of trails off after a period of time. So not the only story.
How about time in these devices? I mean, have they been shown to, if you improve, is the improvement sustained?
It appears to be,
for
yeah.
years?
Yeah. I mean, I don't know that we have numerous years of data, but the cephaly was available in Europe for several years before it was FDA approved, and the TMS as well for maybe a little bit shorter period of time. So it appears to be sustained benefit. And the idea that behind that also is that it's helping, in some cases it may be the device itself is continuing to work, but it's also benefiting patients if it's helping them get out of medication overuse. It's enabling them to return to more kind of normal lives and participate in other sort of beneficial lifestyle changes that we recommend. It's sort of helping get them into almost an upwards spiral, so to speak. So some of them probably could discontinue the device after 2 years and still maintain that benefit. We don't know. That'd be an interesting thing to look at. So the last device I'm going to talk about, and this is the new kid on the block, is the non-invasive vagal nerve stimulator, also known as GammaCore. Thank you, Vanna. This is a device that was just approved in April and is actually just now becoming literally available to prescribe to patients in the US. It's been available in Canada and Europe for a bit longer. This is what it looks like when it's being used. So it's applied to the vagal nerve at the carotid in the neck on either the right or left side. And this is a little different from the previous two devices. So this device was approved for acute treatment of episodic cluster headache, which, as you know, if any of you watched my talk a couple months ago at Harborview, cluster headache is a very, very debilitating disorder, and we have very few proven effective treatments for it and a lot of really desperate patients. So it's very exciting to have anything at all on the horizon that is effective in cluster. So FDA approved in April of this year, and the approval was primarily based on 2 trials, Act 1 and Act 2, that had cumulatively about 400 patients between the 2 of them, showing that it was effective to abort cluster attacks. And this is sort of a busy table, but I'm just going to kind of focus you over at one end here. So they broke this data down in a variety of different ways, but essentially, so this is actually looking at a percent responders. It's kind of all or nothing. Could they abort the attack with this device or not? And aborting cluster attacks is very different from migraine in that way, so there was a reason why they looked at it that way. Again, we had a sham device and an active device. So this device you do feel on your neck. It's electrical stimulation and it has this kind of a tingly, buzzy feeling. So they used a sham stimulator that caused some tingling and buzzing, but wasn't the full level of stimulation. And you can see that when they looked at the percent responders in all of their cluster patients, there was a trend towards improvement in the patients with the active device, but not achieving a significant result. And when they separated out the episodic from chronic cluster headache is when they really saw this spread. So at that point, you see a really nice response. Again, 40% response rate is pretty par for the course for any treatment in migraine or cluster in the active device, and much less in the sham. And then when you look at chronic cluster, no benefit at all. And they sliced up the data a little bit differently and saw the same effect the other ways they looked at it. So that was a very interesting result. And just as a quick review, episodic versus chronic cluster. So episodic, by definition, is patients who have cluster periods where they're having attacks and then periods of remission, often lasting for months. And chronic cluster is patients who continue to have cluster attacks essentially continuously throughout the year. So that was both interesting and also very disappointing because our chronic cluster patients are the most debilitated, the most desperate, and they're the people that this device does not appear to work for. So the question that was raised by that study that I haven't heard any particularly good theories about is why that was the case. Is there something really different about the physiology of chronic cluster, and is there some way that we could treat those patients more effectively? And then other questions that are ongoing and being studied with this device is, can it also be used for prevention? So like the TMS device, there's some good signal in the data coming out that yes, it can. If it's used on a daily basis, even when someone's not having an attack, it probably does help to reduce frequency of attacks. And it's not yet approved for that purpose, but there's ongoing research into that, which is very exciting because the cluster prevention medications tend to not be very well tolerated and often not very effective. And then sort of in the background, because the data has not been fantastic, but maybe another tool available, this device has also been looked at for both acute and preventative treatment of migraine, and there's some signal that it might be helpful, but it hasn't been looking great, so that's kind of fallen by the wayside. Logistics, this is also an extremely expensive device right now. The cost, we're told by the reps, is going to be about $575 per month. It's effectively a rental. The device gets deactivated at the end of the month. And they're currently actually disposable devices, but when they move to a reusable device, it's going to have like a chip that activates it for only 1 month. So extremely expensive. We are the only center in the area that's participating in this registry. It's not exactly a study, but it's sort of post-marketing research by the company. So patients who qualify for that, which means their episodic cluster is their diagnosis and they are not on public insurance, they can enroll in that registry and get up to a year of treatment at no cost. And the company assures us that they have a big apparatus in place to work with insurers to try to get this device covered under pharmacy benefit, and they intend to provide copay assistance to patients to try to make it affordable. But since it's brand new, we don't have any idea like what percentage of insurers are actually going to cover it. So use is probably going to be fairly limited for the time being, unfortunately. But we're excited about it theoretically. Yeah. And you should ask about side effects. So there's more kind of unanswered questions about what the contraindications for this device would be compared to Cephally and the TMS, where it's really kind of limited to intracranial devices. And because it's vagal nerve stimulation, it makes everybody nervous. Vagus nerve connects to the heart. Is that a problem? And theoretically, when you actually look at the level of stimulation delivered by this device, it's almost certainly below the threshold that would actually cause any problems for the heart. But, you know, would I be gutsy enough to use it on a patient with very serious cardiac arrhythmia? Maybe not. Contraindicated in patients with implanted devices anywhere in the chest area. So, you know, pacemakers, DBS, you know, and anything like that, you wouldn't use it. That's really about it. None of these devices were studied in pregnancy. We routinely prescribe the Cephally device to pregnant patients. There's just no theoretical reason to be concerned about that.
Is this FDA approved for pregnancy?
This one is. I think
Cephally has been as well.
TMS has been not, I don't think.
is-
But anyway,
TMS
so
is probably okay. as
the
well.
company doesn't actually specifically recommend using it in pregnant patients. They're kind of hedging their bets, but we probably would. Any other questions? So just as a summary to kind of, you know, pull things back together, you've seen this slide before. Natalia put this together. This is kind of the big approach to headache. So remember to screen for and treat medication overuse. Remember to emphasize your non-pharmacologic treatment options. And the neuromodulation is part of that arsenal now. So stay tuned.
So we're going to actually be offering, you know, this as a new shared visit for like modified for patients. Like we're going to call it, you know, new things in headaches, because we have many patients who we haven't seen for a year, and they want to see us. If you have any patients who you go like, okay, they just want to hear about the devices, you know, just, you know, let us know, and we're more than happy to show them all the devices. Thank you very much for the attention, and we'll take questions, and you did this good. It's very exciting, right, guys? You know, moving into neuromodulation. Okay.
If anyone wants to come up and play with the devices more, feel free.
So so the TMS is actually charged. You know, so if someone wants to try it, you know, they can try it as well. I don't think we have any. Does anyone have any further questions? Sounds like we answered all the questions.
So one question, and it just comes back to something that I asked before. Certainly, you could instantly, you know, segregate migraine headache patients into those with very strong, really precise family history. You know, they all have classic migraine through 2 or 3 generations. So unequivocal genetic evidence of a hereditary headache syndrome. Patients that have classic migraine, they all get visual aura or something. And I'm just curious, have people separated all these variables out that seem very distinctive and unique to see whether there isn't some uniformity in their response to various therapies that have been tried?
No,
I've not seen that.
Yeah, they have not. So the question was, I'm going to just paraphrase Dr. Branson, but the question is there currently in studies any delineation of patients who we perceive more genetic migraineurs, let's say with aura versus migraine without aura versus other types of migraines. And no, it's not done. Not only that, now that we have our own data, we can show you that it's pretty complicated from the point of view that, let's say, after motor vehicle accident, people who have genetic predisposition to migraine, who never had headaches, will develop migraines that look indistinguishable from people who never ever had trauma. So it's just the final pathway activation, and we don't have the underlying genetic data to show us what is pushing or activating this expression. And it's probably it's going to be much more complicated. It's kind of like epilepsy when we started and had all of those epilepsies that it was NOS, and now we're starting to find out that most of it is genetically determined. We're not there with migraine. We don't have, that's what they're working with the big data sets to try to figure out, how are they different. We're just going by phenotype currently, and phenotype will look identical for most providers. It's even more complicated in the sense that a majority of the current primary care providers do not even use the Migraine International Headache Society criteria to delineate who has true migraines or not migraines. They call, let's say, everything migraine or cluster, whether it's cluster or not. So many people use the term quote-unquote cluster migraine, which is an oxymoron, but what they mean for that is chronic migraine with daily migraine. So we're seeing that many patients are misdiagnosed, and especially what we're seeing in our clinic, that's why we started doing in the registry, is who has new diagnosis, and we're finding a significant proportion of the patients we're seeing have new diagnosis of chronic migraine, medication overuse, hemicrania, and other types of headaches that non-headache experts are not able to differentiate.
Say hi to Sid Gosby.
Yeah, absolutely. Hi, Dr. Gosby.
I would just sort of maybe a response to this question, to really go after, say, the genetics. I'd want 1,000 people in each arm, and probably cleaner endpoints than you're seeing in a lot of these trials where you see some, you've got the placebo effect and you're reducing it by 70% or 60%. And so in aggregate, you're able to average all the results and see these headaches, but now when I start wanting to look at individual biomarkers, I'm not saying it can't be done, it wouldn't be fun to do, but compared to some of the biomarker studies and some of the other diseases with the cleaner endpoints, that may be why you have yet to see those trials being published.
And I think the other
Do
issue...
you want to just, paraphrase his comment, or do you want me to paraphrase it? So the paraphrasing the comment, because the other, audience is not hearing you, is we don't have clean endpoints and clean biomarkers, and, it's exactly alluding to what Dr. Ransom said, it's not really cleanly separated. So right now, let's say we have 2,000 patients that we have all the clinical notes in detail, and we can link them to, Epic. And I can tell you, and we're doing that, we're seeing these patients, so we actually do the diagnosis. Most of the studies that were done, they do the diagnosis just reviewing the chart. And some of these, that are enrolled, it's even more problematic with what is the real diagnosis, and the confounding, the medication overuse, and all of the anxiety, depression. There's layers and layers to, these factors. So that's what we're trying to find out right now, even simplistic, the multimodal treatment, what are the pieces that need to happen, and even that's very complicated to do. The majority of our patients have problems with sleep, problems with anxiety, problems with depression, newly medication overuse, and all of those are layers and layers, and so many patients, if we can get them off medication overuse, about 50% of patients improve, 50% don't. So so a lot of these devices, as Jenna alluded to, if you can just stop medication overuse, in many people you can get better. And many of these devices allow the people to have other alternative option. So if I were to just come to you and say, okay, you have to stop Tylenol, you might not listen to my advice because you say, well, that's nice, but what should I do? I have severe headache, or triptan, right? So if I give you an option, you go like, great, I can use cephalin. We have many, many patients who do that, and they get out of chronic headaches and have hardly any headaches. And is it the cephaly, or is it resolving the medication overuse? I think no one is looking into that, that closely. So it's complicated, but we're moving forward in headaches, so we're excited.